So with that, if there's no questions, we'll move on to the next step of our agenda. We are going to hear from the folks down in Pullman. Whether you like Cougs or not is irrelevant at this point. Stacey Aggabao is the Director of Emergency Services for Pullman Regional Hospital, and she's going to walk us through some of the things that they have worked on within their hospital and their systems down there in Pullman.
Okay, I think so. So, as you know, Pullman is a population of about 27,000 now, and that includes our student population. And so, 5-6 times a year, we have an influx of about 30,000 individuals that come into the city for weekend events for football. And our activities usually start around Thursday at noon. So we have influx of quite an influx of individuals coming from wherever, planes coming in starting noon on Thursday, and they don't leave until afternoon on Sunday. So we have quite a large expansion in our community. And so I just wanted to preface what Chief said, that it really is helpful in planning because you want to be prepared. You can't prepare for everything, but a couple of events happened that made us realize we probably need to look a little bit more about preparing for some larger events. We know these events are coming, but we haven't had any disasters, and so we didn't want to have that happen. So I wanted to just thank Bill Whitman for putting our presentation together because he was quite helpful in getting us ready. So this was either event planning or not. So if we didn't plan for it, we were going to have a disaster, and we kind of had a premise from 2014, so that's what prompted us to prepare for 2015 football season. So just some history. I don't know if I can, how he's got this presented on here. So WSU home football games bring approximately, he's got 20,000, but it's about 30,000 visitors to Pullman. For some fans, the alcohol consumption and the acute alcohol intoxication significantly increases the unscheduled care needs in the community. So we see often an influx of alcohol. We do staff a physician at the EMS station within the stadium itself so that they can screen patients as, you know, there before they're sent to the hospital, just kind of as a triage. We have discovered that Halloween has become Hallowed Week in Pullman. So they start the week before, and there are events that continue out throughout the week until Halloween is over. So it's quite the event. And what happened in 2014 is Halloween was on a Friday night. There was a football game on Saturday. We knew that. We had regular staffing for Friday night and had staffed up for Saturday. But what we didn't prepare for was that we had 14 patients brought in to the emergency department that required observation for acute alcohol intoxication within a short period of time. So we have an 8-bed ED, one of which is our decontamination room. So we have very limited space. And when you only have 3 nurses in the dock and a CNA on duty, 14 patients is a lot at one point in time, and most of them are belligerent or combative, so you have extra security risk. A few weeks later, I don't know if any of you remember, but Apple Cup 2014, it was -10 on the turf. It was freezing rain. So not only did we have an influx of 30,000 people into town, but we were dealing with inclement weather, which brought motor vehicle accidents. We had roads closed. We had patients with hypothermia. We had football players and cheerleaders who had been outside since early morning that were suffering effects of hypothermia. And we had a patient surge as a result of the football game in combination with that inclement weather. The night shift saw more than 40 patients from 7 p.m. to 8 a.m., and 32 of those arrived between 7 p.m. and 12 o'clock. And 32 to about 46 is our average for the 24-hour period of patients on a regular weekend day. So that was a huge influx for us. 8 of those patients were admitted. 2 of those required intubation due to alcohol intoxication, and 22 patients were transported by EMS. Several were brought in by law enforcement, and also some were self-reports. They came in on their own. So as you can see, we were not prepared. We did not have the staff in the hospital. The house supervisors and the staff on board could have called for a disaster and implemented incident command, but they chose not to. The OR crew happened to be in-house, so when they finished their surgeries, they were brought down to the ED, and they were the second crew to help in the ED to help get the patients out. And by midnight, most of the chaos had been handled and taken on. So what happens when you have Halloween and a WSU football game on the same day? You don't want to know. So based on those 2 events that happened in 2014, we decided that we needed to do something to prepare for 2015 because we knew we had a Halloween weekend, people coming into town on Thursday, and we knew that parties were starting on the weekend before, and every day during that week there was some sort of activity in the community related to Halloween. Whether it was one local bar having their Halloween parties, whether it was the fraternities and sororities having their Halloween mixers. We had the basketball teams and the baseball teams having trick-or-treaters at Beasley Coliseum the night before the football game started. So we definitely knew we needed to prepare. So we got a group, Dr. Mickelson, who's the medical director for the emergency department, and I got together and we're like, we need to pull a group of people together to see what we can do to prevent any future disasters happening. So we got PR staff. I asked Pullman Fire and EMS to participate because we work very closely with them at the stadium and in transporting patients. We had Pullman Police, WSU Police, and then we had the WSU Emergency Services come and participate in a discussion and planning session about what we could do to help maybe eliminate a disaster from happening. So our goal for our group was to provide a continuity of service to the community in light of the anticipated surge. So we wanted to be able to take care of our own patients and the patients that we had, those who just come in with chest pain, but also some of those that would come in surging from the activity in town. In 2014, during Apple Cup, that is our highest patient volume times. We had no inpatient beds that time, that weekend, to admit to the floor. So we couldn't, patients that needed to be admitted from the emergency department had to be transferred out to either Colfax or Gretman or to Spokane. So we knew we were high volumes for 2015, and we expected high volumes for 2015 and Apple Cup weekend, so we needed to make plans to what we were going to do with patients who needed to be admitted. And then we wanted to coordinate efforts with the PRH staff and the pre-hospital providers for patient care. So one of the important things for us was to be able to communicate with EMS to say, here's what we're having. We need to institute we are disaster medical control for Whitman County and Nessota County and the lower 9 regions. So what would happen if we became so overwhelmed that we couldn't handle that? We asked Spokane to help us coordinate those efforts if need be. But we also wanted to be able to communicate with EMS because they're so used to just bringing us patients. Like, we needed to be in constant communication to let them know, like, we're overwhelmed. We've got patients self-reporting. We have no beds. We need to start diverting to our 2 local facilities. So that piece of that communication was really important. And our objectives then were to recognize that the historical surges of patients on home game weekends and Halloween especially, that both events were happening on the same day in the same year. I'm so happy Halloween's on Monday this year. And there's no football game. So we established an ED observation unit in same-day surgery. This is a 12-bed unit that after 5 o'clock in the afternoon is not utilized because we don't have OR, usually after 6 o'clock unless it's an emergent case or an urgent case. So we recognized that we had this space that we could potentially use for like the yellows and the greens or someone who just needed general observation but wouldn't be taking up inpatient beds for our chest pains or traumas or something that would need a higher level of care. And then we knew we needed to increase our staffing levels in the appropriate areas of the hospital in preparation for the surge. So we typically have on a normal weekend night in the emergency department, and then we already talked about that, and share the action plan. So we did share our action plan with the area hospitals and the public safety providers, and then we also shared it with Spokane County so that they knew what we were doing. So our action plan, going back, our normal staffing on a Friday and Saturday night, we have a doc, 3 nurses, a CNA, and a HUC, and that's it. A health unit coordinator, good question. So your unit secretary. And so we knew that in order to be able to take care of maybe a possible influx of 20 to more patients, we were going to need to increase our staff and be able to utilize beds in same-day surgery as an observation unit. Patients would be seen and screened in the emergency department, but then would be moved to an observation unit. So we created an observation unit instead of having to admit to the floor where patients might only be there for 2 or 3 hours and then be discharged home. So we developed this hospital-wide plan to care for the anticipated surge. It included increasing staffing levels in key areas. We had extra nurses in ICU, med-surg. They also brought in extra CNAs that could help transport patients. We created the observation unit in same-day surgery, and we chose to utilize 8 beds because for ENA standards, standard ratio to nurse patient care is 4 to 1, so we knew we could have 2 nurses over there with a maximum of 8 patients, and then we had a CNA over there that could help with that. Notify and communicate with the area hospital, community public safety staff, and then utilizing HICS concepts for event management. An event window would be, we decided would be from 1900 hours on Friday through 7 a.m. on Sunday, November 1st. We used the watch rank advisory alert would be sent to area hospitals and the other DMCCs in Region 9 so that they would be aware that we were in this situation. Pre-hospital care providers will communicate from the scene or earliest possible time to PRH. So again, helping us to be able to divert patients from the emergency department if we needed to. And then the DMCC will be activated if the surge exceeds our capabilities and patients need to be transported to hospitals. And Bill did contact Spokane County, so if we needed them to take over our DMCC control, that they could do that for us. This is just a picture of our cute little department. So this was a message that was sent on WatchRack. Patient surges anticipated during the WSU Stanford football game and Halloween weekend. Pullman Regional Hospital staff has been increased from 1900 hours on Friday through 0700 hours on Sunday. Local hospitals and pre-hospital providers will be informed of any significant changes. DMCC may be activated if the patient surge exceeds anticipated numbers. So for Friday night, we had our normal staffing in the emergency department, which was 3 nurses, a CNA, a doc, and our unit secretary. And then at 7, we opened up the same-day surgery unit with 2 extra nurses and a CNA. And then the inpatient units had extra staff as well so that they could manage more patients on admission. We had 1 physician from the emergency department who volunteered his time to come in at 10 o'clock on Friday night, and he spent his time in same-day surgery so that there was direct contact with the physician because the unit is obviously separated from the emergency department. So he was gracious enough to offer his time both Friday and Saturday night to spend his time in the same-day surgery unit, having constant communication with the nursing staff there. And then we had on-site medical control as well at the stadium during this football game. So weather, we were lucky, ranged from about 40 to 60 degrees. It was 52 at game time and raining. It wasn't freezing rain. We had 30,012 attendees at the game, and our hospital surge activity was 69 patients in those 36 hours. So from Friday to Sunday morning, 69 patients can be a little about 20 patients over average for us. So our overall outcome, our same-day surgery overflow was a success. I wanted to just say, from 7 o'clock until midnight, the ED saw 9 patients. So that was pretty quiet for a Friday night for us, interesting enough, when it being a party weekend. From Saturday at midnight, or the 24 hours on Saturday, they saw 37 patients. And then Sunday, interesting enough, after the game, from midnight to 700 hours, we saw 23 patients. Even on a normal game day weekend, minus weather, usually by midnight, 1 o'clock, we maybe see 1 or 2 patients. So our influx, what we anticipated was our influx would happen early, and it actually happened later than what we anticipated. So there were some learnings from that we'll talk about later. 13 of the, 14 patients presented to the ED in a little over 2 hours shortly after midnight on Sunday, which normally we would have maybe have anticipated a little bit before or even on Friday night going into the game weekend. 13 of the 14 patients were intoxicated and had injuries or illnesses related to their intoxication. And under normal staffing conditions, there's no way that these patients would have been seen and cared for safely, because on a normal Saturday night, we would have had 3 nurses, a doc, and no CNA and no unit secretary. So we would have had the house supervisor come down and assist. So with all the additional staff that we had, it was very interesting. We put it out to the staff to volunteer to work. So it wasn't, they were mandated to come in. So I had an ER nurse at all times in same-day surgery, but we had one of our OR nurses. She worked both nights, which was pretty impressive because she's not used to taking care of drunk patients, and she volunteered her time. We had an OB nurse that volunteered her time in our same-day surgery unit, and they had fun. They actually said that they would do it again. And so even our own ED staff, we have a lot of nurses who have young children who Halloween's a fun time for them. We had 7 vacation requests for Halloween Day, and we couldn't give any of them. So they made their own arrangements and actually had staff that volunteered to work. So that was a really important lesson for us, is to make sure that the staff were a part of that decision making and that they could choose to work versus being mandated, or knowing that we would have to call them in if we actually had a true disaster and them just not wanting to come to work. Pullman Fire and EMS saw 28 patients during that 36-hour period, and 16 of those were transported to PRH, and they had no problems. They did Pullman Fire did a quick response vehicle on Saturday, Halloween after the football game, which was pretty calm for Halloween. So they had someone out in College Hill just driving around being able to do quick responses for patients. And then the QBR was placed on Greek Row with two EMTs. They triaged, either canceled the ambulance or kept them coming depending on what needed to be done. And then that took a huge load off of the ambulances for triage, as well as the police department that was doing triages out in the field as well. One of the things was future changes would be to staff a paramedic and an EMT to be able to provide quick ALS access if needed, and have dispatch call them directly without bothering the station crews, keeping them in service to confirm calls. So there was a few learnings that the fire department had from having their QBR out. And we lost the football game. Yay. So guess what that does? It pisses people off and they go party more. One of the things, so in our outcomes, the overflow area was a success, and we were able to see all of our patients in the ED and treatment went well. We may have been overstaffed at times because we didn't have any patients go to our same-day surgery unit for the first 6 hours we had it open. So those staff were down in the ED helping out, and then eventually they had, I think they had 5 patients overnight that stayed there. And then we had extra staff in same-day surgery during day shift on Saturday as well, in case there were any lagovers, or if they're still drunk, they need to sleep it off and wait. And I think by 8, 9 o'clock, most of those patients had been discharged home. So then the staff that was there for 12 hours was just kind of stuck. So we did allow them, if the emergency department itself wasn't busy, we gave them the option of going home if they wanted to, or they could stay and work because they had volunteered time. So there were several hours, about 12 hours total, where we were really overstaffed and didn't actually need the staff that we had, but we're glad we had them. So what did we learn? Pre-planning for large community events with subsequent patient surge is beneficial for patients and staff. The repurposing of the same-day surgery for the ED observation worked well. One thing that we did learn is that we needed to do a little bit more training on charting for those staff who volunteered that weren't actually emergency department staff. So just spending a little bit more time going through the process of how to admit and discharge and chart on those patients. Some of the same-day surgery stretchers don't work well for moving patients. So, you know, they're kind of stiff, or they have some rooms that have chairs, but we didn't use the chairs, but they are not emergency stretchers, so they're a little bit different, and they don't roll through the hallways as well. So, some staff were not familiar with the charting system. The daylight savings time change happened at the same time. So we had a trifecta, which meant that we had a few problems entering patients into Meditech and Pyxis. So we had about an hour gap where some of our patients, they were actually in the department, but when the time changed, they couldn't chart on them because the system didn't recognize that they were still there, because it was before their time of, it's crazy. So there was a few little hiccups there, but it came during our surge of patients. So something else to think about is downtime charting, which we didn't, and going back to your technology, if you don't have phones and computers and what have you. So that was an interesting thing that none of us thought about. We didn't even think about it. It wasn't even on our minds. We were just more worried about taking care of it. We did have an extra clinical coordinator, so as a house supervisor, she did come in to help Saturday night from about 10 to 4, which was great because that was during patient surge. So the main house supervisor could keep an eye on the rest of the departments, OB, med-surg, and ICU, and she could just manage the ED and the same-day surgery observation unit. So that was very helpful, especially during the surge. And what we're looking at is that maybe we should do that on every weekend. We think that we might be seeing the surge, so that they do help us a lot just on a daily basis, helping to triage patients. So if we can have them there on a game weekend or another weekend that we might have a surge, having that extra supervisory person there would be very helpful. And then, let's see, having security staff there was beneficial and should not be changed. I did not want my staff to be in same-day surgery with drunk patients who had the potential to become violent without having access to help. So normally we have individuals who are security. Most of them are retired or off-duty police or just strong men in the department from 8 to 2 on Friday and Saturday. And so we increased their hours to 4 a.m. Both nights, and I had one stationed in same-day surgery. So if there was issues with the patients, there was someone there for safety. They could also help with transport and helping to get patients rides home and escorting them back to the waiting room, because we did not want patients wandering the halls and maybe ending up in our inpatient units unescorted. So we did not allow any family members or friends, you know, because when one sorority girl comes, the whole house comes. We did not want them over in the same-day surgery unit area, because in order to get to that unit, you have to walk past the inpatient units, and we didn't want the noise and the disruption over there, and for safety reasons. So we did have extra security. So in our improvement plan, we met on Tuesday following the event, and I had the staff that participated and all the other individuals. We sat down and went over like what went well, what didn't go well, what did we learn. One of the things that we recognized is that we might want to have a SANE nurse on call. We had 2 sexual assaults that came in on Friday night at the same time and 2 on Saturday. And for us, that's a big deal, because right now we only have 5 nurses that are SANE trained, if they're on duty, they get pulled off the floor to do the sexual assault. It takes up a room, and it takes them off the floor, so then you're short-staffed. And that's just kind of how our plan works now. So we did not have anybody on standby to come in and do those exams, so we were scrambling to not take staff off the floor. Materials needed to be restocked in the ED both Saturday and Sunday on these weekends. We did stock same-day surgery with extra supplies that would normally be used in the emergency department that wasn't there, so that wasn't the issue. We don't have someone from materials management in-house restocking our Pyxis systems for supplies on Saturday and Sunday. Oftentimes they'll just leave us an extra cart of those things that are typically used more often, like IV start kits and IV fluids and urinals and emesis stations. But because we had such a huge surge, we were running low by Sunday night, and so that was something that we needed to look at, maybe replanning for, instead of having just the cart, having them come in on our bigger weekends and just making sure that we had the things that we needed to have. We did have extra linen in both departments. What we did learn is that we needed to change the staffing times for same-day surgery area to not end at noon on Sunday. Our premise is that we would end at 7 a.m. if there was anybody left over in the same-day surgery observation unit, that they would be taken back to the ED to finish out their observation stay there. What we learned and what we know now is that Sunday mornings tend to be, people are recognizing their injuries from the night before, or the doctor's offices aren't closed. So you've got both community and these event-related incidents coming all in on Sunday. And so our emergency department was a little bit overwhelmed on, or could have been overwhelmed on Sunday had we not kept, if we'd had patients to bring back. Most of those patients were able to be discharged out of the department and not have to come back. So next time we'll plan to keep that unit open until noon and maybe not open it until midnight on Friday and have a little bit more flexibility with our hours. All staff working in the ED surgery need to know how to use the charting system, and we had done some education with the OR nurse and the OB nurse, but they just needed a little bit more because they don't use that system often. And then consider moving our patients to same-day surgery once labs have been drawn and we were waiting for the results if the ED doctor approved. So our process is that they had to be seen in the emergency department by the physician, either the physician that was going to be stationed in same-day surgery or the primary ED physician. They would have their primary workups done, and then once they were stabilized, could be moved to the observation unit. And so instead of waiting for the labs, let's just move them and go from there as long as their vitals were stable and they were not at risk for airway management issues. And then just looking into different ways to transport the patients, just because the gurneys we discovered are not very mobile. And management of the computer charting and Pyxis systems during daylight savings time, that really had never been an issue before because it happens at 2 o'clock in the morning. We don't usually have patients, and we had a surge. So just what do you do when you can't chart on a patient for an hour because the system doesn't recognize that they're there? And then housekeeping, we did have housekeeping on call, but they were not staffed, and so that was just another thing to have that extra hands there to help clean up the area. I was there on Sunday morning at 6 a.m. to kind of help discharge patients out, and then we put same-day surgery back together again and prepped their rooms for Monday morning so that their staff didn't have to do that. We didn't want to disrupt their work area, and we felt that was very important because they were helping us. We didn't want to ruin their patient's day. And that's a question. It's a lot.